Alrighty, let's start the week with some fun anatomy. Okay, this week we are going to go through some thigh and knee anatomy. This might take a while, but I'll try and make it as concise as possible for you guys, and we'll be doing heaps of clinical in between to keep it interesting. Okay, we'll start off with the movements. Just like upper limb, for lower limb, you guys will have to remember, unfortunately, the dermatomes and briefly the myotomes of the legs. So just to recap, a dermatome is an area, it's over here, it's an area of sensory, like an area of skin, which its sensory is supplied by a specific spinal nerve root. Whereas a myotome is a group of muscles supplied by a singular spinal nerve root. So just remember dermatome, dermatologist, skin, myotome is for muscle. And over here, we've got a good little poem that Jess found out of somewhere to remember the myotomes of the lower limb and what actions they do. This is going to be really important once we start doing clinical skills in a couple of weeks, where we do examinations of the different myotomes and dermatomes. So in your spare time, please look over these couple of slides and try and memorize the dermatomes and the myotome movements. Okay. So, but in general, the nerve supply of the lower limb, it's pretty simple. Basically, the lower limb is structured into compartments. So we have an anterior compartment, a posterior, and a medial compartment because the thigh is just a really big area. The anterior compartment is supplied by the femoral nerve, just like the femoral artery and the femoral vein down here. And the posterior compartment is supplied by the sciatic nerve, which is this big boy over here. Which is the cause of sciatica, if you've heard of that. And a good way to remember it is that it comes down the posterior leg, because with sciatica, patients get a lot of lower back pain and pain that radiates down the leg. And the medial compartment over here comes from the obturator nerve. And remember, the obturator nerve right over here comes through the obturator foramen in the obturator canal with the other obturator people, and it supplies the medial leg, thigh. Cool. So that's basically it. Those are the three main nerves of the lower limb, and there are a lot of minor branches that come off of each one, which is why in pictures of myotomes like this, you see a lot of areas. These are just the different branches of the main nerves. Okay, but to delve into a bit of specifics, we're going to go through nerves via plexuses. So plexi. So in the upper limb, we already learned that we have the brachial plexus. For the lower limb, we have the lumbar plexus from the lumbar vertebrae, obviously, and the sacral plexus. So for these two plexi, you luckily do not have to memorize like all the braiding and the branches like we had to do in the brachial plexus, which was a nightmare. But we'll just be going over the main nerves that come out of each one. So the lumbar plexus is higher up than the sacral plexus, and this basically is in charge of the anterior and the medial thigh. You can kind of remember this because if you can see in this picture, the sacrum kind of angles back posteriorly more. So the the nerves that come out of the sacral plexus are more for the posterior thigh. Okay, but first the lumbar plexus. We've got 6 nerves. The first 3 are mostly for the pelvis and stuff that you'll learn in year 2, but the bottom 3 are very important to remember. If you remember, femoral, as we said before, is the major motor anterior nerve for the anterior compartment, and the obturator nerve is the major motor medial compartment nerve. Off the femoral nerve, we have a saphenous nerve that comes out that gives some sensory innervation to the medial leg. In case you didn't know, by the way, this is the leg over here, like the calf region, and this is the thigh region. So when I'm saying leg, I don't mean the entire leg, just the bottom leg. So anatomy is fun like that. But yeah, basically each of these major nerves, they're so big that they both provide sensory innervation and motor innervation, but definitely remember femoral, obturator, sciatic as the 3 big motor guys. Okay, so going down to the sacral plexus, again, the main one's honestly just a sciatic nerve. And the sciatic nerve has 2 portions, a fibular portion and a tibial portion, which means exactly what you think it means. Basically, when you get down to the leg, it splits into 2. And the fibular nerve is in charge of innervating the anterior and lateral leg muscles, whereas the tibial goes down the leg and innervates some of the foot muscles, but we'll cover that in next week's PSP. As well, we have a posterior cutaneous femoral nerve, which is really similar to the lateral femoral cutaneous nerve. And these, like there's lateral ones over here, if you can see. And these are basically cutaneous nerves that give innervation to the skin of different areas of the thigh and leg. Cutaneous means like, not deep around the skin area. And femoral in the femoral region. So that's basically it for the nerve supply. Remember, sciatic nerve, femoral nerve, obturator nerve are the three big guys, and there are a lot of branches, some of which I haven't covered in this, but I think this is like pretty good for what you need to know mostly. Okay, next, arterial supply. So arterial supply, if you haven't watched this video that we posted on YouTube, do watch that. It's a lot simpler than you might believe. But a quick summary is that the arterial supply of the thigh region is mostly from the femoral artery, the popliteal artery, and the obturator artery. So the femoral artery comes from the abdoaorta through the iliacs down to the femoral region, and then it becomes a popliteal artery. So it's just one straight artery that comes down and supplies the anterior thigh muscles. And remember that when the femoral nerve goes around to the popliteal, it actually winds around to the posterior, the back of the body. So it gives off various genicular branches over there to supply the knee joint. And just quickly, the obturator artery, like the obturator nerve we talked about before, it's very medial. So it gives off a lot of branches for the medial thigh. But just watch the video and it will all make sense. Okay, and now venous drainage. We haven't touched on venous drainage too much because it's basically the same thing as arterial supply. So basically in your lower limb, we have deep veins and we have superficial veins. Basically, the way that venous drainage works is that you get blood coming, so like blood being drained from the skin into the superficial veins, into the deep veins. The deep veins go all the way up to the vena cava, go into the heart. So it's kind of like the opposite of arterial supply, where it comes from the heart, then goes to the big arteries and the arterioles and the capillaries. So yeah, deep veins in deep fascia, superficial veins in subcutaneous tissue. Pretty basic. So in the thigh/leg, lower limb, we have two main deep veins and two main superficial veins. The deep vein over here is the femoral vein, which becomes a popliteal vein, and it drains into the external iliac. Basically, the exact same thing as arterial supply. We also have a profundus femoris vein, which joins the femoral vein just below the inguinal ligament, and these just drain the thigh muscles. At the bottom here, the popliteal vein is formed by three veins in the leg, which are the anterior tibial, the posterior tibial, and the fibular vein. So these join up just below the knee, become the popliteal, and that runs all the way up, eventually into the vena cava. Now for the superficial veins, we have two. We have the great saphenous vein and the small saphenous vein. And basically, the great saphenous vein drains into the femoral, whereas the small saphenous vein drains into the popliteal. And the great saphenous, as you can see here, it moves up the medial side of the body. Basically, I think it joins the femoral vein right underneath the inguinal ligament as well. And the small saphenous vein ascends up the posterior. So we're looking posteriorly here, up the posterior thigh and leg, empties into the vein in the fossa, in the popliteal fossa. And that's basically it for venous drainage. Okay, so what can go wrong when these veins don't really work? So veins are different from arteries because veins have valves that prevent the backflow of blood. This is important because arteries don't have this because they're really muscular, and veins also have to work against gravity to get the blood like from the bottom of the foot all the way back into the heart. So because of that, we have valves. However, sometimes these valves can become incompetent. They just don't work anymore because the pressure is too large, and blood can flow back into the superficial veins instead of going into the deep ones. So this is not good. This results in a lot of pressure being in the veins, and eventually the vein just can't stand it anymore. The valves just stop working and it just becomes distended and dilated as it tries to compensate for the additional blood in there. So that's basically it. Varicose veins is just when the valves don't work and the veins become dilated. This causes a lot of pain in your lower leg and looks like this. There's a lot of different treatments which you can read about later, but that's the main crux of the issue. Okay, now apart from varicose veins, we also have a condition called deep vein thrombosis. So this, put simply, is just a blood clot being formed in the deep veins of the leg. Why the leg? Because there's lots of gravity working against it, extra pressure, and that's where we actually have deep veins at all. Technically, thrombi can happen anywhere in the body, and they can be arterial or venous thrombi, but mostly we deal with DVTs. So what happens is a blood clot forms, it clogs the vessel, and it causes pain and swelling because blood can't move through anymore, and it starts to hurt a lot. This can result in rapid pulses, patients fainting, coughing up blood, having a lot of pain in their foot, ankle. But the real issue comes when part of this thrombi breaks off and becomes an embolus. So by the way, a thrombus is a blood clot, and the piece of the clot that comes off of it is called an embolus. So yeah, so when that happens, remember that the venous drainage goes from the skin to the superficial veins, to the deep veins, into the vena cava, into the heart. So this little blood clot is small enough to go through all of those stages, go up into the vena cava, move through the heart, and eventually it usually gets lodged somewhere in the lungs. Why lungs? Because, I mean, the veins are a lot smaller there, whereas the heart has a lot of larger chambers. However, it can occlude and cause issues in the heart as well. So this goes into pulmonary circulation, blocking blood in the lungs, causing death. It's a real big issue, and it's a really acute issue and can cause death really quickly during surgery or just in day-to-day life, I guess. Okay, now for the bones. So the bones of the thigh region is really simple. We just have a big femur, thigh bone, and we have a little patella bone. And interestingly, this patella is actually completely enclosed in the quadriceps tendon. So I'll show you on 3D anatomy in a second, but the patella is really simple. Basically, we have a base at the top and an apex at the bottom, which is very confusing, but the apex is pointy, so I guess that's why we do that. And if we flip it over, we have a medial facet and a lateral facet. Okay, so as you can see over here, the patella is completely covered in the quadriceps tendon. And basically this is really good because it adds stability and it makes the joint more strong and able to have a wider range of motion, but it can cause other issues that we'll talk about in a second. Okay, let's look at the parts of the femur then. I'm sure you guys have probably looked at the femur so far and seen all the million different parts, which is pretty confusing. So I'll give you a rundown of different areas and why it's important to remember them. Ooh, okay, so we'll start off with the head. The head of the femur, pretty simple. It just forms the hip joint. It's covered with articular cartilage, and we have this little depression called the fovea of the head of the femur, and this is where the ligamentum teres attaches. So below the head, we obviously have the neck. Wow, we did not know that. So this neck connects 135 degrees to the shaft, which you don't need to know, but I pointed out because this angle allows like greater range of movement at the hip joint. Yeah, okay. And then we have the greater trochanter and the lesser trochanter. These are just two bulges right below the neck of the femur, and the greater trochanter attaches the gluteal muscles. If you remember from last week, if you recall the avulsion fracture, that's a type of fracture where a piece of bone is broken off because the muscle contracts too quickly and too strongly, which can happen in lots of athletes. So what can happen here is that an avulsion fracture of the greater trochanter can occur when you contract the gluteus medius too hard. So a piece of bone breaks off here, so yeah, be careful in the spot. Okay, so for the lesser trochanter, the exact same thing, but it attaches the iliopsoas muscle instead of the gluteus medius. And again, avulsion fracture can happen there, less common though. Okay, let's move on to the surfaces. Okay, so we'll start here. So we're looking at this anteriorly again, remember? And this is a line we call the intertrochanteric line, which just means between trochanters. And basically it's the site of attachment for another ligament called the iliofemoral ligament, which is the strongest ligament of the entire hip joint. And it just attaches some other hip joint capsule ligaments, but after it passes the lesser trochanter down here, it actually becomes some other lines that we'll discuss in a second. But first, let's flip over and look posteriorly. So we're looking from behind now. And over here, we have the opposite of the intertrochanteric line on the other side, which is the intertrochanteric crest. It's just the same thing on the other side. Not much to say about it. Okay. Oh, one more thing, by the way. I mentioned how there's an angle over here that increases the hip joint movement. Well, the reason why the shaft of the femur is kind of slanted horizontally, sorry, slanted, not vertically, is because we do this to bring the knees closer to each other so that we have a stronger, so that the knees are closer to the body's center of gravity so that humans are more stable. So I found that interesting. Okay, now we're looking posteriorly again, and we're looking at this line, which you may have heard of, called the linea aspera. So that in Latin literally means rough line because it's a rough line, wow. And basically all these rough lines are areas where different muscles and ligaments attach, and they're rough so that attachment happens more easily. But what happens is that the linea aspera at the bottom splits into the medial supracondylar line and the lateral supracondylar line. And if you go up here, it splits into two superiorly as well, which is the gluteal tuberosity over here and the pectineal line over here. I wouldn't bother remembering which muscles attach here, but it's pretty good to remember what these lines are called. Now, moving down to the bottom, we just have a few more places to discuss. Okay, so finally, we're looking posteriorly again. We have the condyles, the medial condyle of the femur and the lateral condyle of the femur. And these are basically two smooth surfaces that articulate with the leg bones. Yeah, that's basically it. And as well as condyle, we have an epicondyle. We have the epicondyle of the medial side here and the lateral epicondyle here. And basically these are important because this is where the different medial and lateral collateral ligaments attach to basically keep the knee joint intact and keep the patella stable and everything. Not the patella, sorry, the tibia. And basically in the middle, finally, we have the intercondylar fossa, which is this white space over here, which is a deep notch between the two condyles. And the ACL and the PCL, the cruciate ligaments, attach here, whereas the collateral ligaments attach here. So collateral, cruciate. Okay. Cool. So hopefully that all made sense. You can look at the notes back here again if you want, but we'll get straight into the clinical. So what happens when the femur is fractured? Well, there's different types of femoral fractures, but usually it's happened in the neck or the shaft of the femur. So in the neck of the femur fracture, patients present with a shorter externally rotated leg, which is pretty interesting because the distal part of the fracture is pulled upwards and rotated as a result of the break in the bone. This usually happens in older women with osteoporotic bone that have low energy falls. Why women? Because women get osteoporosis more often following menopause. And there's two types of neck or femur fractures. Either happens within the capsule or outside of the capsule. So an intracapsular fracture inside the capsule is probably more dangerous because it can damage a lot of the arteries that we talked about last week, the femoral circumflex arteries that perforate all the way around here. And what can happen when these arteries are broken is that we have a vascular necrosis of the femoral head, which is where necrotic bone forms, the femur dies, it shrinks. And this happens because there's no other kind of blood supply that can go into this specific area and really compensate. So that can become a medical emergency. But an extracapsular fracture is usually more okay. Basically, blood supply to the femur is still intact because the circumflex arteries don't go down here. Okay, so femoral shaft fracture. So a femoral shaft fracture often causes leg shortening, similar to a neck fracture, and apparently they often happen as spiral fractures. So there we go. It'll be pretty good for you guys to maybe remember these type of fractures. They're pretty simple though. Oblique is oblique, spiral is spiral. But what happens in the shaft fracture? There's a couple of complications, but first of all, the profundus femoris artery can be at risk, and maybe the femoral artery too. But if you remember, the profunda femoris artery moves really closely to the femur because it is called the deep femoral artery. So that can be lacerated or just interrupted when there's a fracture of the femoral shaft. And also the sciatic nerve, which is the huge nerve coming down the posterior leg, that can also get injured as well when the shaft is fractured, especially in proximal and distal injuries, because I guess that's when it comes into closest contact. Again, happens a lot in elderly low energy falls or also high energy injuries, MVAs, motor vehicle accidents, all of that. Another issue that can happen with it is compartment syndrome, but we will get onto that later. So yeah, femoral shaft fracture. Okay, so we're at the end, we're nearly finishing. So we're down at the knee joint now, and the knee joint is pretty simple. It's a hinge joint. It like does this. It flexes, it extends, it rotates a little bit, and it's made by the thigh bone, the leg bone, the knee bone. There's two articulating surfaces, basically meaning that the tibia moves with the femur moves with the patella, but the patella doesn't move with the tibia just because of its location. And yeah, here you can see the patella is completely enclosed in the quadriceps femoris tendon, basically your quads, and the patellar ligament from below. Okay, neurovascular supply to the joint. Arterial supply is genicular. Genicular just means knee. So anastomoses around the knee that come from the popliteal artery. The nerve there's a rule in anatomy where like any nerve that crosses the joint innervates the joint. So femoral, tibial, common fibular nerves, they cross the joint, so they innervate the joint. And the venous drainage comes from the back of the knee. The anterior posterior tibial veins, along with the fibular veins, unite to make the popliteal vein, as we said before. So yeah, that's pretty simple. Just remember the tibia is like so much bigger than the fibula, so it requires two veins, one at the back, one at the front, and those three veins all together form the popliteal and move up as the femoral. Okay, so what happens when the patella is injured? So this is pretty much common sense as well. Dislocation happens when there's a lot of high force impact on the patella or the knee suddenly twisted, and usually the patella is dislocated laterally. I think this is medial dislocation, but you can kind of see the effect over here. Happens in women more commonly because we have a greater Q angle, which you can see in this diagram here, due to the shape of our pelvises. And patella fracture, there's basically two main ways you can fracture a patella. One is if you have like direct trauma to the bone directly onto it, which would suck, or you suddenly contract your quads too quickly and it actually tears off part of the patella, again in athletes. And this can cause a few different types of fractures, which is really similar to they have the same names as the femoral fractures, but this is just a different image to show it. Oh, yes, and if a patella fracture is fractured into two, which it often is, the top is pulled superiorly by the quads, the bottom is pulled inferiorly by the patella ligament, because, you know, when you flex, that's what it does. Okay, cool. So knee joint, apart from the bones, we have some other little guys in the knees. And first off, these are the menisci. So we have a medial meniscus and a lateral meniscus, and they're basically fibrocartilage that just act as shock absorbers, like over here, like the little cushions, I guess, that make the knee joint more stable. And they basically attach the bottom of the condyles, as we saw before. And basically damage occurs when the knee is twisted. Often when it's weight bearing, as you can imagine, it twists, it puts a lot of friction, and it may tear the menisci when the bones are moving against each other. Clinical skills, I'd really recommend you guys use Physiopedia, like Radiopedia before physios. They give you a lot of good videos and explanations on how to test for different ortho stuff like this. But just quickly, McMurray test, Athlete's grind test, Thessaly test. We'll go over this in a couple of weeks, but those are different tests we use to test, oh my gosh, for menisci injuries. Okay, so what happens when it tears? Well, this happens a lot in sports, a lot in elderly people as well, when you squat and twist your knee. If your medial meniscus is injured, this causes pain on medial rotation, and lateral meniscus tears cause pain on lateral rotation, which is pretty simple. You don't need to remember the types of tears. I just added these for interest. Okay, part 3, bursa. Apart from menisci, we also have bursae, just like we have in our elbows and in our upper limb. So we have 4, suprapatellar, prepatellar, infrapatellar, and semimembranosus. And they're exactly where you think they are. Semimembranosus is just between the semimembranosus muscle and the gastrocnemius calf muscle, down at the back here. So if your bursa get inflamed, that's no good. It usually happens to the prepatellar over here and the infrapatellar down here, bursa. So prepatellar bursitis, we often call housemaid's knee because you're kneeling down, and it's friction between the skin and the patella. Because remember that the patella is actually more superior, like it doesn't touch the tibia at all. It moves with the thigh bone. And the infrapatellar bursitis, we call the clergyman's knee. As you can see, it puts more friction between the skin and the tibia, so the patella isn't actually involved. So yes, just remember infra and prepatellar bursitis are the 2 common ones, because it'll be pretty hard to kind of put a lot of friction over there or back here. Okay, anyway, okay, we're nearly done. So finally, the knee joint has a lot of confusing ligaments, but there's basically 3 different types of ligaments. There's a patellar ligament, which we talked about before. It's down here. Does the same thing as a quadriceps femoris tendon, does the opposite to the quadriceps femoris tendon by pulling the patella down. And then we have collateral ligaments and cruciate ligaments. So a collateral ligament, they stabilize the hinge motion of the knee so that the knee can flex and extend well. And the cruciate ligaments, cruciate means cross, so they connect the femur to the tibia and basically prevents the 2 bones from moving too much. But yeah, you can see here the anterior cruciate ligament, PCL, these cross in the middle, whereas the collateral ligaments are around the outside at the epicondyles, as we talked about before, the epicondyles of the femur. Yeah, basically. So ACL it's anterior, so it prevents anterior dislocation of the tibia, as you can see here. So it prevents the tibia from being pushed too forward over here because it's holding it back. Whereas the PCL, which you can't really see, but that prevents posterior dislocation of the tibia. So yeah, that's it. Clinical tests that you can Google in your own time, which are pretty interesting. So these tears happen quite a lot. I'm sure you've all heard of an ACL tear and whatnot, but for MCL and LCL, for the collateral ligaments, you should know this thing called varus and valgus, if you've heard of that. So varus is basically a deformity where the legs like go out too much, and the valgus is when the knees come too close and the knees are too close together. We got taught like the way to remember this is imagine a Russian farmer riding a pig saying that is my pig or something, and imagine him riding the pig like that. So you can think about that if you want. But yeah, so usually because these are collateral ligaments on the side of the knee joint, they are damaged when you have lateral blows to the knee or medial blows to the knee. Whereas the cruciate ligaments often happens when you stop too quickly and like your tibia and your femur just like move out of place, I guess, because sudden changes in direction put a lot of pressure on the joint to keep those bones together. Yeah, same thing for PCL. Okay, cool. So a blown knee, you may have heard of that. That's basically just an unhappy triad, which has the ACL, MCL, and medial meniscus all damaged, as you can see down here. Basically, it happens when there's a lateral blow to the knee joint while the foot is fixed onto the ground. Yeah, just remember ACL, MCL, medial meniscus. And these are some summary diagrams that I think are really good. Okay, we're nearly there, I promise. Last thing is the muscles, which I'm not going to go into too much detail today because I believe that studying the lower limb, just remember the muscles in terms of compartments. Anterior compartment, medial compartment, posterior compartment, because each compartment has its own artery and has its own nerve. Individual muscles in each compartment may have like tiny differences in like which nerve or compartment it belongs to, but just remember this table basically. The anterior compartment, it extends the leg. Posterior compartment also extends the leg and extends at the hip, whereas the medial compartment adducts the hip because, you know, it's an adductor, it's close to the medial line. And these are basically the muscles in each region. Teach Me Anatomy basically teaches you everything. So I'd suggest just looking at these, making these into like Anki image occlusion cards and looking at that. But also it would be good for the exam if you guys can try and get some images like these and try to be able to identify different compartments and individual muscles from cross sections like these, as well as specimens like these. So yeah, it's pretty self-explanatory, so I'll just let you guys look at it in your own time. But something that can happen in your lower limb with your muscles specifically is compartment syndrome, which is basically when a compartment has a lot of pressure built up because of fluid, because of something that's just expanding in there, and basically results in the muscles degenerating, results in ischemia, a lot of necrosis. It's a big issue. If anyone's watched Grey's Anatomy, it happened when this guy was like covered in cement and he got compartment syndrome because obviously cement was on him. But yeah, usually it happens in the thigh, in the anterior compartment of the thigh, because of all the neurovasculature structures over there. And so what happens is that you have some kind of injury, some kind of fracture, and that causes swelling and blood and other liquids to just accumulate in that compartment. However, fascia doesn't stretch. Fascia isn't like muscles. It doesn't really move or stretch, and the pressure just builds up and it has nowhere to go, decreasing the blood flow, decreasing oxygen, nutrients, everything. And then eventually you have to do a fasciotomy, which is just cut through the fascia to relieve the pressure. And that should usually be pretty good. But last thing is to remember the 5 P's of compartment syndrome, which are pain, pallor, which is like lightness of color, paresthesia. Paresthesia is like tingling or burning sensations, whereas anesthesia is like no sensation. Pulselessness, and paralysis. So yeah, compartment syndrome. Hot tip, use anatomedia for muscle prosection images. That's, yeah, okay, cool. So finally, I just have some slides on the inguinal ligament because I just want to remind you guys that it exists, and some other spaces like the femoral triangle, adductor canal, that I'd recommend you look into in your own time. Popliteal fossa is very important as well. So try and remember all the contents that cross through here. This is basically just the area at the posterior region of the knee that's formed in a diamond by these four muscles. Lots of neurovasculature goes through there. We can check for a pulse there. It's pretty clinically important. So just take a look at that, because sometimes the popliteal fossa can swell, and usually it's for two different reasons. It's for a cyst or it's for an aneurysm. So a cyst is basically the semimembranosus bursa being swollen. So remember, it's the one back here. Whereas these two are caused by friction, this is caused by a lot of swelling. That can be from arthritis of the knee or trauma. And this is cold, it's non-pulsatile, whereas a popliteal aneurysm, it's warm, it's squishy, it's pulsating. And that's when the popliteal artery is just really weak and the artery keeps dilating. It's like when the veins dilate as well. This is a popliteal aneurysm. That can cause leg ischemia, causing paresthesia, getting rid of plantar flexion. But basically just remember, this one's warm, this one's cold, this one has a pulse, and this one doesn't. So I think that's all for today. So
okay, so if there's additional questions, yeah, feel free to put them in the chat. I'll keep an eye on that, and the rest of PSPupper will as well. Okay, so talking a bit about somatic sensation, this is mostly about the skin related stuff and all of the mechanoreceptors inside the skin. So first of all, we've got two types of skin. So you've got your hairy skin, which is basically where you've got hair growing, and glabrous skin, so that's just meaning smooth. So glabrous skin, think of like your palm area, hairy skin's like the back. So within your skin, we've got four main mechanoreceptors. So first we've got, first we've got the Meissner's corpuscles, which are sitting over here, pretty close to the surface. You've got your Merkel's discs, which are sitting around about here. Pacinium corpuscles, these are the onion ring ones here, and then Ruffini's isn't shown in this image, but I managed to get one here. Important to note is just all of these mechanoreceptors, the nerve that travels back to the brain is going to be your A beta nerve fibers. So these are the afferent ones. And it's important to know because later on when we talk about pain, this is going to be via a different system, just because you want to be reacting very quickly to pain. So there's like a different system for that. So main thing to kind of remember is like your structure will determine the function, and then the function is going to determine the location. So there's basically a table on the next slide that summarizes it all. So I might kind of flip back and forth between the two slides to kind of pull everything together. So we'll start off with Pacinium corpuscles. So this is going to be the onion-shaped one. And because it's located quite deep inside the dermis, oh, by the way, just like a bit of a recap, this is epidermis, so top of your skin, this is dermis, and then there's going to be muscle and subcutaneous tissue underneath. So Pacinium corpuscle, it's sitting quite deep in the dermis, meaning you're going to have quite a large stimuli to kind of activate it. So think of this as being responsible for your deep or like great pressure and like vibration stuff. And the way it kind of works is you can see the onion shape, right? So what happens is if someone like pokes you really, really hard, what happens is that causes the onion rings to kind of spin, and all of the sodium ions outside are basically going to be able to pass through into the center. And the center is where you actually have the afferent nerve fiber. So then the sodium is basically going to flood in, and that's going to cause the action potential to basically go and run. So that's pretty much the Pacinium corpuscle. Because it's deep, think it's not super accurate at pinpointing the location. So it's got a very large receptive field. And this is a fast adapting fiber, meaning you need to constantly stimulate it in order for something to be like, in order for your brain to know that something's like stimulating it. So next we've got the Meissner's corpuscles. So this is the one that's sitting over here, capsulated pretty high up in dermis area. Since it's pretty high up, we're thinking, okay, this is probably going to be light touch. And because it's high up, it's also pretty accurate at pinpointing where exactly it is. So it's got a small receptive field. And the way this one works is kind of, you've got lots of small discs inside. So basically a small like prod poke, something like that, is going to cause like the sodium ions to like flood in, because it's going to basically shift these discs to the side to allow the sodium to pass through. Next up, we've got the Merkel's discs. So these are the ones that require a sustained light touch. And okay, where is it? Yeah, so this is also pretty high up. So we're expecting this to be a small receptor field as well. The way it works is actually your Merkel's discs, they pretty much have a lot of small vesicles inside. And the way these vesicles release all of, I guess, the neuropeptides is if something's stimulating it. So think about it as like, if someone's like constantly pushing you or something, that's going to stimulate your Merkel discs to constantly be releasing stuff from its vesicles. And that's why, as long as you have touch being sustained, you're going to have an action potential that's firing. Yep, and last one is Ruffini's corpuscle. So as you can kind of see from this image here, it looks a bit different from the other ones. And the way it works is this is actually full of collagen. So think collagen, that's mostly going to be present in the dermis area. So that's where you're going to find your Ruffini's ending. Let me just check the chat. Oh, wait, okay, Rachel's replied. Okay, all good. So, whoops. In that case, that's also going to be responsible for sustained touch, in the sense of, think if something's like pressing against the collagen, that's going to move it, and that's going to allow the influx of sodium ions, because it's located a bit more deeper compared to your Meissner's and your Merkel's discs. That's also going to have a larger receptor field, so less accuracy, more like stronger sustained touch. So you can have a look at this in your own time. I've also chucked a link to Khan Academy. This has a bit more detail than what you probably need to know, but it's pretty comprehensive, so would probably recommend. This is once again just a general overview. So we've got the Pacinian corpuscles, so for vibration. You've got your Ruffini's, and which once again is like large, vague borders, because these are sitting deeper. The ones that are sitting higher up are going to be your Meissner's and your Merkel's discs. So this is going to be for your touch sensation. In terms of proprioception, so proprioception is just kind of your sense of balance. We've got three main proprioceptors in the body. The lecturer, I think if they've done the same thing, they've only taught two, but there's three. So yeah, anyway, so basically, first one is going to be located in your muscle spindles. It's important to recognize it's in your intrafusal fibers instead of the extrafusal one. So it's just like the one on the inside. And the way it works is kind of like, I guess, if you like hold your arm up and you close your eyes, you know that your arm is lifted. And that's because like your muscles in your arm are basically saying like, oh yeah, like this is how the muscle is positioned. So you kind of know what's happening to your arm as a response of what the muscles are telling your brain. Next, we've got the Golgi tendon organ. So like the name, it's located inside your tendon. So you can see all of this stuff in here is your Golgi tendon organ. And what that does is basically, it depends on how contracted your muscle is. So that's going to tell your brain like how stuff is like operating. So muscle spindles relates to the length of your muscles. The Golgi tendon organ responds more so to like the actual contraction of the muscle. So the third type, we've got the joint receptors. As you can imagine, it's located inside the joint, tells you like how like the position of the joint. So you guys will be learning about this tomorrow, I'm quite sure, with the peripheral nerve exam. And what happens, you guys probably did this for upland, but yeah, basically you like wiggle their fingers up and down and stuff, and get them to basically say like, is the thumb pointing up or down? That's related to like the joint receptors inside the joint. This one's just a good overview as well. So three types: you've got the joints, you've got the muscles, you've got the Golgi tendon organs, all coming together to give you input into the brain. Okay, so that's pretty short. Next, this is the very big bulky section. So everything about the nervous system. So the way that we're going to go through this, big overview, peripheral nervous system. Now talking about a specific type, the autonomic nervous system, and talking about it in terms of the neurons that are involved, neurotransmitters, the receptors that the neurotransmitters act on, and then how the relevant drugs all impact this kind of stuff. And then we'll talk a bit about like how the whole entire body regulates how the system works. So peripheral nervous system. In terms of your whole entire body, you've got kind of two big systems. It's your central nervous system and the peripheral. So central is very central, consisting only of your brain and your spinal cord. Everything apart from that, that comes out of the spinal cord is called your peripheral nervous system. So in terms of peripheral nervous system, we can classify it into two types. This is a bit of a revision from last time, actually. So somatic is all your voluntary movements, so your skeletal muscle, and the autonomic, which is involuntary stuff. So autonomic nervous system is responsible basically for your homeostasis, to make sure that everything's going well. And we can divide this once again into two types: sympathetic, which is basically responsible for your fight or flight, or parasympathetic, which is your rest and digest. So talking first about the somatic. So somatic, remember, is all about the voluntary movement, so consisting mainly of your skeletal muscle. So all of this stuff is what allows your muscles to contract. And a few characteristics: it's only got one single neuron per muscle fiber. So this is just like a kind of small schematic of what it's going to be like. So it's going to be myelinated, and the neurotransmitters are going to be acetylcholine acting on nicotinic receptors. And one characteristic is this kind of receptor, so nicotinic receptors, they will always be excitatory, so it will always result in muscle like contraction. So that's all you have to know about that. It's just like one slide. In terms of autonomics, this is for homeostasis, and they basically help modulate your activity. So they've got two types of neurons. So you've got your sympathetic and your, well, not, okay, yeah, there's like two types. So you've got your sympathetic and your parasympathetic. And one thing to kind of recognize is it actually depends on the location that characterizes whether or not it's parasympathetic or sympathetic, not that function. So sympathetic fibers will always arise from T1 to L2, L3, and parasympathetic, think either side of your sympathetics. So it's going to be like cranial nerves. You don't have to know about this in too much detail. It'll be covered in second year. And the sacral nerves, which are like further down from your lumbar area. So how the ANS system basically works, you've got a ganglion, and then the preganglionic, which is just before the ganglion, and the postganglionic, which is after the ganglion, those two types of nerves. So this is different from somatic. Somatic has one, autonomic has two. So what a ganglion is just like a collection of cell bodies. A lot of cells are like synapsing here. Also note that the preganglionic, this is going to be myelinated, and postganglionic is going to be unmyelinated, and they directly synapse with the effector organ. So types of neurons and also like, so types of neurons connecting them to the receptors and the neurotransmitters. So SNS, once again from T1 to L2, L3. We've got two types of kind of like nerves. So first of all, talking about the ganglion. So at the ganglion, so we're talking about this particular nerve over here. For sympathetic nerves, you're going to be releasing acetylcholine, and that's going to act on a nicotinic receptor. And then at the target organ, well, yeah, you might as well see this one as well. So at the target organ, that's going to be your noradrenaline acting on either an alpha or a beta adrenoceptor. So noradrenaline adrenoceptor. So next we've got the parasympathetic neurons. So at the ganglion, it's got the same kind of neurotransmitters and receptors, but this time at the target organ, it's also going to release acetylcholine and act on a muscarinic receptor. So this pretty much is just a summary of what I explained before. So you've got your somatic nerve, simple, one thing, acetylcholine to your nicotinic. You've got the parasympathetic, which basically has acetylcholine on a muscarinic, and sympathetic, which is noradrenaline on an alpha beta adrenoceptor. So that's the ganglion. Another thing that you can kind of know, not too important, is just this is longer than this, and it's something of interest. So let's say an example might be like if you have really sweaty palms, that might be due to like your sympathetic nervous system acting too much. So they can choose to kind of cut this particular neuron, and the reason that they would choose to do that is because the myelinated neuron is actually going to be shorter, meaning this neuron is going to be longer. So if they cut this, there's less of a chance that they're going to damage like further structures over here. So yeah, that's just something to kind of like know, I guess, of interest. Yeah, once again, another summary diagram that you guys can check out. This kind of shows the length of the preganglionic and postganglionic fibers, so that kind of illustrates that quite well. In terms of the effects, so sympathetics, they usually are responsible for your fight or flight. So think what happens essentially when you're trying to run away from, I don't know, a serial killer that's behind you. So expecting like pupil dilation because you want to see well, bronchodilation because you want to breathe, tachycardia, your heart's like beating really fast. vasoconstriction and dilation, it depends on whereabouts it is. So in your blood vessels, it's vasoconstriction, versus in your skeletal muscles, it's vasodilation, because you want to get more blood flooding to the skeletal muscles. GIT, you've got decreased GIT because you don't want to be worrying about like digesting your food when you're like running away. In terms of parasympathetics, it's literally just the opposite. One good mnemonic is dumbbells. So like dumbbells, diarrhea, urination. You guys can read through the rest of that. And once again, another summary diagram. Okay, so this is a bit of a confusing thing. Have you guys got an Electra or like a light board video from Michelle Lazarus yet? Yeah, I'll get someone to put that in the chat, because if you have, then I won't go into this in too much detail. If not, then this might be very confusing. Okay, I'm getting radio silence. Oh wait, yep, you guys have seen this. Okay, so I might run through this very quickly then. But yeah, at least you guys will have like a little bit of a foundation to go on. So basically, in terms of how this works, you've got a cell body that's going to be located in the spinal cord. We call this the IMLCC, so the interomedial lateral, I'm guessing like half medial, half lateral cell column. Basically, that's going to go out via the white rami communicand to the sympathetic trunk. Sympathetic trunk is just your elevator that will take this particular like nerve wherever it wants to go. So it's going to basically go up and down until it decides that it wants to get off that particular elevator level. And then what happens is it's going to synapse there and basically go out. So how does this work? So it's going to go out via a gray rami communicand, and that's going to basically take it to wherever it wants to go. That's pathway number one. Pathway number two is it decides to not synapse on this particular like elevator. It instead decides to travel out, synapse at a prevertebral ganglion, which is just like a collection of cell bodies that's not inside the sympathetic trunk. And then after it synapses there, then it's going to travel via another gray rami communicand to wherever it wants to go. That's pretty much the gist of it. Michelle goes into a lot more detail, and like it's a really good light board video. So would recommend having a look at that. But this is just like another diagram that takes you guys through, and they've classified it in terms of preganglionic and postganglionic. So that makes it a lot better as well. Okay, so receptor types. Yeah, so we were talking before about muscarinic and your adrenergic receptors. Turns out it's a lot more complicated, and there's like a lot more different subcategories. So in terms of muscarinic, we've got 5 different types. The main ones that you need to know are just M2 and M3, but everything's here. You can think about it in terms of like a person. So M1 is basically head stuff. So like salivation, you've got your like bronchoconstriction kind of stuff happening here. M2, you do have to know. So this is going to be cardiac contraction. Once again, if you're moving down, like heart area. M3 is like gut area. So this is going to be like the glandular smooth muscle stuff. M4, M5, no one actually knows what it does. There's some implication that it does these kinds of things. So like general CNS kind of stuff, but yeah, it's kind of an area of ongoing research. So don't worry if you don't know this, because researchers don't either. Okay, so in terms of relating this to the drugs. So in terms of drugs, actually, Stella, do you want to go through this, or do you want me to run through it? Okay, I guess I'll run through it, and then if Stella has anything to add, chip in.
Yeah, go for it.
Yeah, so Stella's like the farm god amongst like all of the PSP. So if you've got farm questions, go to her, but I'll run through this quickly. So in terms of nicotinic and muscarinic, we usually give like muscarinic agonists or antagonists, just because nicotinic, if you remember, if we go back a few slides, there we go. Nicotinic receptors are also present at the ganglion. So if you give nicotinic receptors with the purpose of stopping it here, you're also going to affect all of this stuff, which can be rather a rip. So we usually go straight for the muscarinic agonists and antagonists. So agonists kind of stimulates activity, and antagonist is going to inhibit the activity. So basically agonists, just think you're going to get PSNS or like parasympathetic effects. Antagonist, you're going to get sympathetic effects. So everything that's written here basically reflects that. So your eyes, if it's parasympathetic, you're going to see constriction, you're going to have stimulated gut motility, you're going to have a decrease in heart rate. versus muscarinic, everything's just going to be opposites. So main drugs you need to know are all of these ones. There should be a few additional ones, I think, on ePharm, but basically just think about it in terms of, is this going to have parasympathetic effects or is this going to have sympathetic? I'm not too sure about a lot of the big ones, but okay, so these ones are mostly your muscarinic antagonists. This pyridostigmine is your acetylcholine esterase inhibitor. One thing that I used for atropine, I was like, okay, atropine is like you're troping along, so like sympathetic effects, muscarinic antagonist. I don't know if that helps, but like, yeah, that was just a really stupid way that I remembered atropine. Anyway, so cholinergic clearance mechanism, this is how cholinergic stuff gets cleared. So if we start from the start, you've got acetylcholine being formed from your choline and acetyl-CoA. So acetyl-CoA comes from your mitochondrion, and then the choline part just like comes together, forms acetylcholine, gets released, acts on whatever receptor that, that's on the next, what's it called, axon. And the thing is, you've got a bunch of acetylcholine floating in the synaptic cleft now. So we need to kind of get rid of it. Otherwise, the next axon is just going to be constantly stimulated. And the way it works is basically we have something called acetylcholine esterase, and that basically breaks it down, and then you get the choline that's recycled, and then the acetate is just like degraded. So the drugs that affect this are your neostigmine and your botulinum toxin. Don't worry too much about this. Actually, no, this one I think you do need to know. It was like later on that you didn't. Botulinum toxin, I think someone had a mnemonic or something, like botulinum was like Botox, which like stops movement or something, so like stops the release, something like that. There should be a massive kind of cheat sheet or something on the Google Drive if you guys do a bit of a search. So yeah, that's all of your cholinergic stuff. So now onto your adrenergic receptors. We've got two types. So you've got your alpha, you've got your beta. Main thing to know, alpha is your constriction stuff, beta is your dilation stuff. So pretty much two types for alpha. You've got alpha 1 and alpha 2. Alpha 1 basically constricting, so vasoconstriction. Alpha 2, a bit of a special case, which we'll talk about in just a moment. But first onto the beta. So beta is basically your dilation stuff. So we've got three types, beta 1, 2, and 3. Important ones are beta 1 and 2. So beta 1 is found in the heart. So beta 1 equals to 1 heart. So therefore beta 1's in the heart. Beta 2 is found in the lungs because like 2, you've got 2 lungs. Oh wait, did I say lungs or did I say heart? Sorry, it's found in the lungs, yeah. So you've got 2 lungs. And this is going to basically have a dilation or dilatory effect in the lungs or increase the force of contraction in the heart. As for beta 3, just know like it does the rest of the stuff. So all the other stuff, it does like the relaxation stuff. Okay, so going back to alpha 2. Yeah, okay, so Stella's just been responding to stuff in the chat. So alpha 2, this is basically involved in auto inhibition. So what happens pretty much is if you have a lot of, I guess, noradrenaline, this is just norepinephrine, so the American way of saying noradrenaline. If you have a bunch of this in the synaptic cleft, there's actually a receptor on the presynaptic axon, and this noradrenaline will bind to this particular receptor to basically tell this axon to like, please stop firing because otherwise we're going to have way too much. So it's a form of auto inhibition. So if you think about it, if you have the A2 receptor not working, you're going to end up with a lot of noradrenaline. So you're going to get a lot of stimulation and hence sympathetic response. So a lot of the ANS stuff, you can think about it, I guess, in a logical manner. Okay, really, really high yield stuff will be this slide and the next slide. So know these two. So main takeaways. So first of all, know this table, but the main stuff that you need to know is first, alpha 1 is going to have a constrictive response, and then beta 1, beta 2 found in the heart and the lungs respectively. Special case is your sweat glands, which are considered something called a sympathetic cholinergic fiber. So what that means is it responds to sympathetic stuff, or like a sympathetic response. However, it's a cholinergic fiber, meaning that it releases acetylcholine and it's going to bind to muscarinic receptors. A bit confusing, but just know this as like the one exception to everything else. Also, never ever give an asthma patient a beta blocker, because if you think beta blocker, beta is the sympathetic stuff. You block that, you're going to get parasympathetic bronchoconstriction and your asthmatic won't be able to breathe. So don't give an asthmatic patient a beta blocker. Yeah, second slide that you do need to know. Main takeaways from this, first of all, your lungs are not innervated by your sympathetic nerves. So you might think it's a bit weird. So then how would you get bronchodilation? The receptors are in the lungs. However, the nerves are not directly innervating it. The way it works is parts in your body are going to be secreting a whole bunch of adrenaline because your whole entire body is connected via blood. Essentially, all of this circulating adrenaline is then going to basically attach to the receptors on the lungs. And this is what causes bronchodilation, but it's not directly innervated. So definitely remember that because that will come up time and time again. Second thing, likewise, same thing for blood vessels. So you've got the receptors inside, but remember also vasodilation and constriction is only mediated by a sympathetic response, not parasympathetic. So once again, a bit about the drugs. So think what kind of effect will this have in terms of like big picture, sympathetic, parasympathetic stuff. So alpha-1 agonist. So alpha-1 agonist is going to promote sympathetic response. So thinking vasoconstriction. So that's why it's often used as like a decongestant. Alpha-1 antagonist, that's going to prevent the sympathetic. So basically causes parasympathetic, which is going to allow you to like have smooth muscle relaxation. So alpha-2 agonists, remember alpha-2 is the auto inhibition pathway. So if you promote that, you're going to have a decreased amount of noradrenaline being released. Once again, antagonist, it's going to turn it off. In terms of beta 1 and 2, you guys will revisit this when you do heart stuff, but basically beta 1, if you add beta 1 agonist, sympathetic response, beta 1 blocker is going to stop sympathetic. So angina and hypertension, that's often because your heart's like pumping too much. So if you give them a beta 1 blocker, that's going to basically stop your heart from working overdrive and then basically help alleviate symptoms. Salbutamol, that's your beta 2 agonist. So once again, bronchodilation. Don't give them a beta blocker. We're almost there. So adrenergic clearance mechanism, a little bit different. The way it works here is basically noradrenaline, blah, 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 synthesized, released. At this particular point, it's basically taken up, and it's either taken up and reused and recycled, or it's then broken down into your metabolites, just like stuff that you need for metabolism. So that's pretty much all you need to know. This image looks really big and messy, but that's just kind of talking about like the inhibition pathway, once again with the alpha-2, and stuff that you can bind to afterwards. So yeah, once again, these are just the drugs that are affecting the noradrenaline reuptake. Pretty low yield. They cover it in one active learning. So if you guys get that active learning and you want to kind of see the answers, pop along here, but don't worry too much about this. Okay, so any questions relating to that? Nope. Okay, so we've got like 5 slides left, almost there, and then a couple questions. So central ANS control is controlled by your hypothalamus and your brainstem. So hypothalamus is just this thing here, brainstem, this massive thing there. So in terms of brainstem, we've got the midbrain, we've got the pons, medulla, and all 3 of them are very important for like staying alive, essentially. So hypothalamus is your big boss. Everything in the whole entire body comes back to the hypothalamus, essentially, or like important information in a sense. So it, first of all, can get information from outside the body, so external stuff, and then it also controls, I guess, like the different set points inside your body, so the internal information. What it does is it basically gets that info, compares it to what it's supposed to be, so the biological set points, and then if it's different, it's going to do something to basically correct it. Different inputs, you've got your spinal cord, which is this thing here, cerebral cortex, and endocrine systems is just stuff that travel in the blood. So that's also going to go back to the hypothalamus. In terms of how it regulates stuff, so it regulates your 5 basic physiological needs. So like all of the stuff that you don't need to voluntarily think about. So energy, metabolism, body temperature, blood pressure, that kind of stuff. One kind of pathology that's not too like dangerous, I guess, is just like if you happen to have like an exaggerated vasoconstriction, you get something called Raynaud's, it's like Raynaud's disease. So your fingers turn white, first of all, because you don't have the blood flowing through. Then it turns blue because you don't have the oxygen going through. And then when eventually you do get that vasodilation, they're going to end up turning red because the blood's going to like flow back. Yep, this you can have a look in your own time. next, just like brainstem, really, really important. If your brainstem is damaged, you're pretty much dead, or like you can't actually do much apart from like staying on a ventilator, that kind of stuff. So we've got 3 parts. You've got your medulla, which is the one on the bottom. This is your vital function stuff. You've got the pons over here, which is like motor control of your eyes and face, and the midbrain, which is more so your like sleep consciousness, temperature regulation kind of stuff. That's pretty much it. Okay, so we might go through a couple questions. Just drop your answers in the chat. So first of all, which of the following receptors is responsible for vibration? So we've got the Meissner's corpuscles, Merkel's discs, Pacinian corpuscles, and Ruffini's corpuscles. Or if you guys have no idea, just say no idea. That's fine as well. Hey, not quite. Good guess though. Good guess. Yeah, so Pacinian corpuscles, these are the deep onions. So think vibration. Vibration is kind of like poorly localized, because if something's like vibrating against like your hand, you can't exactly tell whereabouts it's coming from directly. So deeper in the dermis, Pacinian corpuscles. So which of the following locations are proprioceptors not present in? Extrafusal muscle fibers, muscle tendons, bone joints, and intrafusal muscle fibers. Yep, really good. So it's present in the intrafusal ones, not the extrafusal ones. So which of the following would be classified as a parasympathetic fiber? So from T4, L1, T7, or S3? Nice. So sympathetics, T1 to L2, 3, and then parasympathetics either side. So what kind of nerve does not have a ganglion? So parasympathetic, sympathetic, somatic. Nec nerve just means neither adrenergic nor cholinergic. Don't worry too much about that. Yeah, really good. Somatic. So what receptors do noradrenaline work on? So nicotinic, muscarinic, adrenergic, and glutamate. Yep, nice. Adrenergic. Okay, Tim was recently put on benztropine, which is a muscarinic antagonist, for his Parkinson's. What would not be considered an expected side effect? So think about it in the sense of, what does a muscarinic antagonist do? So are you expecting sympathetic or parasympathetic effects? Bronchoconstriction, really good. And that's just because you're expecting an SNS response. So bronchoconstriction would be what you're expecting. Oh wait, no. You're expecting a sympathetic response. So you'd expect bronchodilation, sorry. Yeah. So when should you give an asthmatic a beta blocker? Yay, that's good. Yeah, never give an asthmatic a beta blocker. Which of the following is the brainstem not responsible for? So we've got respiration, voluntary control of movement, motor control of the eyes and face, and temperature regulation. Okay, we're getting a few different answers here. Turns out it's actually B. So one thing to kind of remember is brainstem. This is like the really crucial stuff. So voluntary control of the movement, that's voluntary. So brainstem won't be responsible for that. Most voluntary stuff is going to come from the cerebral cortex, so the big brain area. And all of the other stuff is stuff that you usually don't tend to think about. So that's why your brainstem would be responsible for those things. Okay, so this is one that's directly out of one of the past exams. So the main clinical use of a beta-2 adrenoceptor agonist is for the treatment of... And just for like, if people don't know, angina is just like heart pain from if you're exerting too much and you've got like a blockage in your coronary arteries. Yeah, really good job. So bronchial asthma. Yeah, this one's a bit of a difficult one because we didn't technically cover these, but think like beta agonist, bronchial asthma is good. And last one, so atropine is useful in treating organophosphate poisoning because it does something. Bit of a clue, organophosphate poisoning is just like you end up with parasympathetic effects. So it's like a lot of salivation, diarrhea, a lot of crying, which is also one of, or like lacrimation, sorry. So that's the kind of stuff that you would see with that. So atropine, what could it do? I don't know, like if you guys are just thinking or just like no idea. Okay, yeah. Oh, good. So basically, atropine, if you think about like the really stupid mnemonic or like tripping along, so it's like sympathetic effects. It's actually a muscarinic antagonist, but it will have sympathetic effects. So what it does is it's going to block acetylcholine action in the parasympathetic nervous system because it is a muscarinic antagonist. As for like the other one, so because it's a cholinergic thing, it's not going to have anything to do with your alpha beta receptors. So B and C are out. Reactivates inhibited acetylcholine esterase. So if you have a lot of acetylcholine esterase, you're going to have more you're going to have more breakdown of acetylcholine, but that's not quite how the drug works. This will be for your pyridostigmine. Inhibits normal ganglionic transmission, not quite, because that would be like ganglion stuff. This is more like towards the end. And that's it. Okay, so yeah, really good job, guys, for like sticking around.